Brought to you by Chemistry.
Hello listeners and welcome back to Brought to you by Chemistry. I'm your host, Dr. Alex Lathbridge, and in today's episode, we're talking about antimicrobial resistance, infectious diseases, and how diagnostics can play a crucial part in finding a solution for this issue. Really uplifting, really optimistic. This isn't going to terrify you at all. Joining me is Dr. Tina Joshi, Professor of Microbiology at Plymouth University, and Dr. Kaamini Walia from the Indian Council for Medical Research. I'm going to ask the most difficult question is, could you please introduce yourselves?
Hi, I'm Dr. Tina Joshi, an Associate Professor in Molecular Microbiology at the University of Plymouth. I sit on the Microbiology Society Council and also on the Science Committee of Antibiotic Research UK.
I'm Dr. Kaamini Walia. I am working at the Division of Epidemiology and Communicable Diseases at Indian Council of Medical Research in India. And I am a microbiologist by training, and I've also trained in public health. And I have been coordinating the activities of antimicrobial resistance initiative at the ICMR for almost 10 years now.
Brilliant. Wonderful. I got two experts here with me, which is nice because I'm not an expert in anything that we're going to chat about today. So, of course, my second question is, with what we're talking about today, could you, one of you, maybe both of you, could you explain what exactly diagnostics are when we're talking about antimicrobial resistance? I'll start with you, Tina.
Yes, certainly. Diagnostics are a way to, I suppose, get surveillance data for AMR infections. They're really important. You can diagnose an infection using very different tests. We've known that with things like COVID, when you go and get a pregnancy test, it's a similar thing. But with diagnostics for AMR, they're really, really important because they allow us to understand how many people are infected with superbugs, so AMR infections, definitely in the UK and potentially globally.
So as I see diagnostics for AMR, they are a guiding strategy for treatment, as well as for understanding the disease burden, as Tina very rightly said, for the surveillance. AMR diagnostics have not received the kind of attention for many years now, which has led to very irrational and misuse of antimicrobials, resulting in increasing levels of drug resistance. That's why there is now focus on improving the diagnostic stewardship and the diagnostics which can help us in detection of the pathogens as well as the antimicrobial susceptibility profiles will be our most useful bet if we really want to progress towards diagnostic stewardship.
Kaamini said, I think it's really important because, we're in a time now where antibiotics don't work particularly well. We will come to a time where they don't work at all in future. And it's incredibly important for us to have diagnostic tests that allow us to effectively basically preserve the antibiotics we have and prescribe them appropriately. So that's one of the key things about diagnostics too.
Okay. And so with that in mind, when it comes to antimicrobial resistance, I must confess, it's not something that I think about a lot in my day-to-day life. So how do you find, the both of you, how do you talk about it to people? How do you raise awareness of antimicrobial resistance to people who might not know it?
So I have spoken to many journalists in the past, and what I learned from talking to them was that many of them do not really understand antimicrobial resistance. They think that the humans become resistant to antibiotics, but that's not the way it is. Antimicrobials are effective against bacteria. Antifungals are effective against fungi, and antivirals are effective against viruses. So it is when these bugs stop responding to these drugs, that is when the antimicrobial resistance develops. And from my working in this space for almost a decade now, I understand that the awareness and the risk perception around antimicrobial resistance is very, very poor in the community, even among the doctors.
For me, I think I do a lot of public engagement. I talk to the public all the time. And actually, the reason I do it is I think it's almost like a moral obligation. I've got to do it because I know how serious the problem is. You see the public and they're very aware of things like climate change. And the reason they're aware of that is because it's almost been explained to them in a way that they understand. There's things they can do about it. But with AMR, it's not much that the public can do, and it's difficult. So when I do talk to the public, I try and raise awareness of AMR and just say, well, actually, our antibiotics don't work as well anymore. I organise events, definitely at Plymouth. World Antibiotic Awareness Week is incredibly important. And I even create like videos for kids. I just recently created an AMR video talking about how washing your hands is incredibly important. So for me, it's about giving simple messages to people and the public to be able to help them feel empowered to do something at least, and to raise awareness of the problem.
So with that, Tina, like what sort of feedback? I mean, okay, what sort of feedback do you get from the, let's say, general public, but from people that you talk to? Like, what sort of misconceptions do they have?
Well, they just think that scientists can find a solution. It's that someone will find a way of dealing with it. And actually the problem is so complex that scientists are saying, well, we need help to deal with this. So I think the public are taking it for granted that it'll just be solved, first of all. The second thing is that they can't really believe that there's not many antibiotics left in the pipeline. They can't believe that these bacteria are evolving so quickly. And I think that's part of the problem with the fact that we're not educating the public properly. We're not saying to the public, bacteria evolve, and we're overusing antibiotics. And of course, they survived before us. They were here on the planet before us, and they're going to be here after our species goes as well. And when you put it into that kind of perspective, I think people think, oh, okay, fine, I get this is a big problem, but why haven't we been told about it? And again, it comes back to the fact that people aren't really interested in telling the public about it, I would say. And by those people, I will point out the media. I don't think the media are aware of how to kind of communicate this problem, because it is a problem and people don't know what to do about it in general. So we talk about governments and policymakers doing things. But again, it's about that whole message of empowering people at home to do something about it. And I think that's where we are not meeting in the middle. And that's something that scientists and policymakers and clinicians and the public need to do better.
We have not done enough to understand the socio-economic and the behavioral drivers of antimicrobial resistance in different countries and the different socio-economic settings. Because we don't know what are the drivers, what is the risk perception, and why the risk perception is so low, we have not been able to come up with an appropriate communication strategies also. I mean, not much. Look at what we did during HIV time, or for example, messaging around tuberculosis. HIV was a very, very complex space to be in. There were ethical issues, there were different kinds of sensitivities, but eventually the socio-behavioral research was such a strong component of HIV/AIDS research that we came up with the tangible solutions, how to convey something to the community. But the same kind of thrust, unfortunately, is missing for AMR. Who should you target? Should you target community? Should you target physicians? Should you target quacks who are dispensing antibiotics? And who should be reaching out to them? So these are some of the real issues that in a country like India, where TB cases are so high, there are different set of problems which follow a set of seasonality, I would say. And then there was COVID for a long time. And there are different drivers of antimicrobial use in our community and the way our doctors dispense drugs. So, but what we understand from the surveys which we have published and one which was also done by ICMR, there is some amount of sensitization around the topic for last few years. But everyone is, information available is rather fuzzy, and everyone is really looking for the solutions. But the fact is now almost 20, 30 years, we don't have a new antimicrobial. These are essentially analogs or combinations that we are depending upon. So this kind of messaging is very important, that just like, you are worried about water, you are worried about the quality of air and climate change.
Okay. I mean, so there is a lot there. And so like with today, and we're sort of looking at diagnostics. Now, diagnostics, I guess, isn't really an area that a lot of people outside of experts like yourselves know about. So, Tina, starting with you, could you explain, what are the different types of diagnostics? And do they all tell us the same thing, or are they used for lots of different things?
Okay, with diagnostics, there are different types of diagnostics, and it depends on what they're targeting. So you can have molecular diagnostics that target almost the DNA inside of a bacterium, and they'll give you a kind of a resistance profile and help you to understand where the resistance is in the genome, so in the DNA of that microorganism, or you can get tests that look at the serology. So looking at the way in which patient's immune system respond to the microorganism. And clinicians will know that'll be CRP tests, PCT tests. And then you can get different types of tests like antimicrobial susceptibility testing, which is what most hospital laboratories do, which is when a patient has a certain type of infection, they're not sure whether it's going to be susceptible to a certain antibiotic. They'll take that sample, take it to the lab, and then do a whole range of antibiotic testing on it to see if an antibiotic will work or won't work. All of these tests are incredibly important, but there's a whole different range of different timescales that can be performed in anyway. So you can have a molecular test that can be performed in an hour or 2 hours, or antibiotic susceptibility testing that takes several days perhaps. And that's because in terms of diagnostics now, we haven't really innovated since the 1940s or 60s. And by that, I mean our gold standards, the test that everyone does for diagnosing infections is agar culture. That's your standard. That's going to tell you exactly what the microorganism is. And we haven't really developed the tech or tested the tech enough to be able to say, let's diagnose an infection right here, right now. That's what I'm trying to do with my research. But there's lots of problems associated with that in terms of research funding.
Okay, I love how every time we have a science, any expert on, the problem eventually boils down to, give us more money, please. We want more money.
Oh, it's just such a cliche, but it's not really, because if you think about COVID and the amount of money that was pumped into COVID, and we solved that, we developed diagnostics, we developed vaccines, and that happened in a very short space of time. It's the same rationale, but actually, maybe controversially, I think that AMR is really much more of a serious problem than COVID is. And if we had the same kind of resource, we would make so much more progress.
So in terms of like pushing innovation forward, like you work, you lead an interdisciplinary team. So how do all those different experts, all those different disciplines come together to develop and make innovations in diagnostic methods and tools and stuff?
I'm really proud to lead an interdisciplinary team. And the reason I do that is because not everyone's an expert on everything. So while I lead the team, I'm not an expert in biophysics, even though I touch upon it. I'm not an expert in chemistry. So I look to the people in my team to provide that expertise. And a lot of scientists exist in silos. They tend to work on their own. But by bringing all of us together with different expertise to solve a problem, like this great grand challenge, I will call it, of AMR, we're actually able to do innovations or create innovations to develop potential solutions. I'm not going to say that development of diagnostics is the solution to AMR, because that's really naive and that's not the case. It's one of the many solutions to helping manage AMR. But for me, I think, innovation cannot occur in a silo. We have to work together to solve these challenges.
So how many different people do you have in your team? Like what sort of different disciplines are we talking here?
So I've got people in my team who are molecular microbiologists, for sure. I've got people in biophysics, people in engineering, microwave engineering, graphene, novel materials development. I've got people in companies who give business development information. So it's taking a whole lot of different disciplines, not just scientific, but also across the other humanities types of areas to come back in and understand how a product can be developed and made. So developing a diagnostic is not just about getting the science right. It's about getting the entire product right so that it's actually going to be used, if it can be used.
And so it's like creating something bigger and better for society in that way, bringing everyone together. And so like with that in mind, Kaamini, I know that you are working on something very interesting. Can you tell us about it, the Antimicrobial Surveillance Network?
So I have been associated with this initiative for almost a decade now. When we started putting together the surveillance network, there were many labs which were working by themselves, but then we really did not, they were all following different SOPs, you could say, standard operating procedures, so different methodologies. So there was no way that we could collate that data and bring out a nationally representative estimate of drug-resistant infections. So that's when we put together this network with 20 tertiary care hospitals, all having very good labs, all having the manual as well as the automated system for pathogen identification and antimicrobial susceptibility testing. So the uniformity and harmonization were the key imperatives for this network. And we really focused on generating quality assured data which is, which can stand any international level of scrutiny, and bring out the country levels trend and patterns of antibiotic resistance from these key tertiary care hospitals. And for last so many years, we have been publishing annually the report from all these hospitals and this network, which is available in the public domain.
Okay, and so what sorts of information are you getting from that? Like if someone were to look at this data, what would they see?
Okay, so this data comes from the tertiary care hospitals. And tertiary care hospitals are, the highest level of referral hospitals in our system. And a lot of referred patients and very sick patients actually land up in these hospitals. So we collect data from all the isolates which are received in the clinical microbiology labs. And that's the data that is used to put out, to analyze, which is analyzed and which is used to put out the kind of a nationally representative. I wouldn't say that's completely representative of the country, but that's representative of the tertiary care only, because the nature of the patients that receive care at the tertiary care are very different from the ones that will go to the community hospitals or the secondary level hospitals.
So with that in mind, like we're based here in the UK, but you're working in India, and we've spent a long time in this series looking at the problem of AMR as it comes from sort of a more British, perhaps European perspective. But when it comes to India, like what are the main challenges when it comes to AMR? Like, are there any specific issues?
As I mentioned, the data that we publish every year is representative more of the tertiary care. But what is happening in the community, we don't know that. Because at the community level or at the district hospitals level, we don't have laboratories, we don't have skilled manpower, we don't have adequate point of care tests which can be utilized in these settings and which can give us an idea of what kind of pathogens are, for example, causing UTIs or sepsis, and what is their drug resistance profile. So these are the challenges that we are facing in collating community level data. And this is something that we really want to bring out in next few years, because otherwise, if you look at the ICMR data, we report very high levels of resistance. That may not be an appropriate reflection of the community levels of resistance, where the use of drugs, something like piperacillin, tazobactam, or carbapenems, is not that high as compared to the tertiary care hospitals. Recently, India came up with a national essential diagnostic list. And under that list, we have made it mandatory that every district hospital must have a functional microbiology lab. So this kind of augurs very well with the overall intent of bringing out AMR data from every level of healthcare. Along with that, I think the government of India also has a focused program towards creating the skilled manpower. But what we need very urgently is the point of care diagnostics.
Tina, I see you nodding your head very much in agreement.
Oh, definitely. I think it's really interesting, the things that Kaamini pointed out, because there is a huge problem with diagnostics innovation. And I think, for example, what I'm trying to do is develop a point of care test, utilizing engineering, microwaves, to reduce the time frame in which we can get a result. So we're looking at around about 5 to 10 minutes. So that's definitely point of care without much processing of the sample. And we're doing that for UTIs at the moment. But the problem that I've got is that while I'm developing in that lab with my interdisciplinary team, the thing is that when you try and get grant funding or you talk to companies and approach them, they already want you to have developed the device to the point of being what we call technology transfer level 4 or 5. So you've got this proof of concept point where you've developed the technology, you've tested it, and then, it's ready to go. And then that's when a company will take it on. But there's no mechanism to allow that proof of concept to get to a point where you can go and test it. And that's where I would say there's almost like a valley of death. There's no way of getting those innovations out there unless there is funding and support, like I said before. And that's a really serious issue, because if we don't have these diagnostic tests, then we will not be able to do the surveillance we need for AMR, and we will be understanding the problem globally. So in LMICs for definite, so low to middle income countries, we need to understand the incidence of AMR to be able to tackle it better internationally, and we're not able to do that without diagnostics development. So for me, I actually think that right now, like with the Longitude Prize, I mean, I applied for the Longitude Prize. I was a bit late, so that was in 2015 or 16 or 17 that was launched. They gave out a seed set of funding to varying people, but they didn't give out any more funding after that. So you've got these people who are developing these diagnostic tests that are basically from companies who've got that money to be able to do that. Whereas, academic researchers like me are kind of left out in the cold, and we're trying to innovate for society. We're trying to do something a bit different because something different is required now for AMR. We're going to be in a situation, I think, in the next 20 years where, okay, our antibiotics won't work, and we're talking about stewardship and protecting our antibiotics. But realistically, there may be no antibiotics left that work to be able to steward. And that's a different conversation entirely. So we're talking now about managing AMR, not finding solutions for it.
Like learning and speaking to experts like you throughout this series, I've just been learning that people aren't doing enough and governments aren't doing enough, and everything is just, there are people like you who have the ability to do these things. Why aren't people giving you the money and the attention and the funding required? It's very frustrating. Ooh, but back to professional Alex. So,
sorry.
No, that's okay. I mean, having mentioned, all of the research and all of the work that's going into this field, I think this is a question for both of you, because I'd like sort of your different viewpoints on this. What do you think that countries like the UK, the US, and generally in Europe can do to help, low and middle income countries to deal with the problem of AMR? Because like you mentioned, AMR is a global problem. It's not siloed to one country. It doesn't stick within borders. It's all around the world. It's global. So how can the UK and sort of other nations help low and middle income countries with the problem of AMR? I'm going to start with you, Kaamini.
So one thing is very clear from the discussions today, that we need good diagnostics. The diagnostics have to be quality products. They have to be available, accessible, and they have to be affordable. Only then we will be able to use them in a low middle income country setting like India. So where does these diagnostics come from? These diagnostics come from big pharma companies, and they, very strategically develop diagnostics for ICUs patients, for something like which can be utilized in a patient who's very sick and is in an ICU. Those diagnostics I see, they are available in India and they are selling very fast. But for something like typhoid, we still don't have a good diagnostic. And we don't have a disease burden. So that's why we can't make a strong case for typhoid vaccine. We can't make case for, how much is the disease burden for typhoid in India. We have seen the successes of some of the RDTs like malaria, something like a dried blood spot assay for HIV, or glucose strips for diabetes. We have seen how they revolutionize this space. So there is a definite need for a good diagnostic, just like, all the countries and especially India became a hub of generics for making drugs. I think we need a similar focus and similar collaboration with other countries on diagnostics now.
What about you, Tina? What are your thoughts? How can the UK and other countries help?
I think there's a danger in saying the UK can be this saviour for other countries. I will say that, it's almost like a bit of a colonial mindset there, that we can go into LMICs and tell them what to do. I don't think that's really the case. It has to be a collaborative endeavour to be able to get some of these diagnostic conversations off the ground. Exactly what Kaamini was saying. I think the thing that the UK is doing, which is fantastic at the moment, is we've got these 5-year AMR action plans, and we're about to have another inquiry into the next 5-year action plan in the UK. And part of that is opening dialogue with LMICs and trying to establish and continue incentives such as the Fleming fund that Kaamini was talking about. But again, it's creating that mechanism. It's that almost like a push incentive for people to develop diagnostics so they can be used by the communities that need them. And again, those pipelines aren't there. It's talking about those pipelines again. So trying to talk about that with LMICs and varying countries in a collaborative way is incredibly important. But definitely, we've got a lot of work to do. I don't believe policymakers are particularly interested in AMR. The reason I say that is because, of course, there are other things going on, the cost of living crisis and other things globally that policymakers potentially need to divert their attention to. But AMR is this slow, silent pandemic that is going to have a massive, massive effect on medicine. It already is. We're just not seeing it very clearly at the moment because of the lack of surveillance data. But people in the field, like us, we know that this is happening. So for us to open dialogue is incredibly important to make sure those dialogues are kept open too, and that people aren't working in silos.
I mean, you mentioned that you do a lot of work talking to the public and sort of educating people, making videos about AMR and getting people to understand. I mean, how do you do the same thing for policymakers? Like, how do you get them to sit up and take notice?
Well, with policymakers, I try and go to policy events like the Westminster Forums, definitely in the UK. I try and contribute to things like any government inquiry, like the AMR Action Plan inquiry or the bacteriophage inquiry that's going on in the UK, contributing to POST, so Parliamentary Office of Science and Technology Horizon Scanning. And you just try and get your message out that diagnostics is incredibly important. We need to start investing in diagnostics. But whether people listen is a different thing entirely. And again, it's about putting yourself out there, and it's difficult to do that as an academic. I mean, I've gone to these things and said, this is what I do. And people just like nod their heads and walk away. And it's about perseverance. So I'm really passionate about this because I think this is a really strong message that people need to understand. That's why I keep doing it. But I think for many of the people who've tried to keep talking about AMR and get a door shut in their face, I think that's incredibly hard. And I can see why a lot has not been done. And I'll give you a really nice example. I'm not speaking for this person at all, but look at Lord Jim O'Neill. He wrote the AMR reports in 2015, 2016. Indicated that diagnostics was the issue, that the solution, to AMR, one of the big solutions that we should start investing in. That's why the Longitude Prize was announced and made up. But since then, and Lord Jim O'Neill has said this on many occasions, there's been no progress. And that's because of policymakers, that's because of NGOs, that's because of world governments not taking this seriously. So the question is we have to try and get these people to understand, but how do we do that when they're not interested? And the only thing I can say is perseverance.
Evidence generation, I think, is a very important part of that. Once we, keep on generating evidence and bring it out to the knowledge of public as well as the policymakers. And one of the most important aspect is the economic impact of AMR, I think, and the advantages of and the cost effectiveness of having a good diagnostics in terms of the impact on, the expense on the antimicrobials for treatment. So those are some of the things that we have been doing in India to bring it to the notice of policymakers. It's not that they have started noticing as yet, but when they will decide to notice, we will have some data out there. For example, it takes 40% more, it is 40% more expensive to treat a drug-resistant infection than the drug-sensitive infection. When a strip of antibiotic costs only $2 and your test costs something like $10, who's going to use a diagnostic test? But then the long-term advantages of using diagnostics has to be brought out through systematic studies and its impact on the antimicrobial use as well as the antimicrobial trend. So this is a kind of a long game that I think we all are in now, and we have to continue to do our bit.
I mean, you mentioned there that real difference in economic costs. If the drugs cost $2 and the diagnostics cost $10, these are sort of figures there. It makes more sense to do the cheaper option. Then for you, what what would a perfect diagnostic look like that could help alleviate some of these issues and perhaps change how society views these things and how policymakers view these things?
For me, a perfect diagnostic, as I mentioned, is accessible, available, affordable, and it is of a good quality. It should be available at all levels of healthcare. Something that, government is promoting for free, something like COVID tests, which were made available in the shortest possible time frame. Then something that has a very short turnaround time, maybe 2 to 4 hours is something. I would be realistic. I wouldn't say half an hour. I wouldn't say 1 hour. Maybe 2 to 4 hours is a turnaround time. And something that has a good shelf life.
Oh, I like that. I like your wish list. It's a good solid wish list. There's a wide variety of things that we can hopefully get at some point. So Tina, I know that in a lot of cases, in the last 20 years, technology has been moving forward, and we've had more and more technology put into the palm of our hand with mobile phones. So are we going to see any innovation there? Can sort of mobile phone technology be helpful when it comes to diagnostics? Could I somehow have a diagnostics app on my phone, or could my doctor have one?
Potentially, yeah. So apps are going to be very important. There are definitely apps available right now that can help clinicians with antibiotic stewardship. There's definitely a role for apps there, but there is a danger where you don't want to get patients to sort of triaging or diagnosing themselves. So there has to be managed in some way. So there's not mass panic that someone thinks they've got certain infection. And it's almost like self-diagnosis with Google. We don't want that to happen with our patients. We want some sort of mechanism to be able to allow this technology to be used better. I think in terms of technology, for me, you talk about a dream diagnostic. To me, that's a tricorder, and that's what I've always tried to develop. And it sounds really, really crazy. But when I was young, I watched Star Trek, and I thought, God, if I could develop a technology similar in that way that would be able to detect a disease, we're talking about something that's completely innovative, and we are quite far away from that at the moment. But the point is that the mobile phone technology is so small, and we've got so much innovation there over the years that technology has been available. We can translate that to diagnostics research. And that's some of the stuff that I'm trying to do right now.
And for people who were cool and watched Star Wars instead of Star Trek, could you explain what a tricorder is?
I like that. A tricorder is a device used by Spock, one of the characters on Star Trek, to potentially, and Bones, of course, to potentially scan somebody from a distance and diagnose what kind of disease or issues that they may have with their body. And it was a device that's obviously, in theory, able to detect anything.
So my final question for both of you, right? If you had one key thing for listeners to take away, be it people at home, be it policymakers, people in government, what would your one key takeaway be? I'll start with you, Tina.
I think for me is to understand that AMR is just as important as climate change, and that we need to do something about it, and to increase AMR awareness before we lose the most precious drugs that we need.
Yeah, whenever we think about antimicrobial resistance, we only think about antimicrobials. I want people to also think about diagnostics when they think of antimicrobial resistance, because we will not be able to reduce antimicrobial pressure, which gives rise to drug-resistant mutants, unless we reduce that pressure. And diagnostics is a very important component of that. We need more investment in diagnostics. We need more focus on diagnostics going forward.
Wonderful. Well, thank you both so much for joining us here today. And now it's time for some news. Brought to you by Chemistry's producers met up with Dr. Hilary Jones to discuss the importance of public health advisors on television, delivering complex health issues to the public, and what antimicrobial resistance means for the future.
Hello, I'm Hilary Joshi from the Royal Society of Chemistry. Joining me today is my colleague Lizzie Radcliffe, and also the fabulous Dr. Hilary Jones.
Hello, here, and hello, Lizzie. I'm very well, thank you. Can't complain. No colds, coughs, no sore throat. So far, so good.
This series is about antimicrobial resistance. But I think what we want to kickstart this interview is by asking you if you can just tell the listeners a little bit about your background as a doctor, and then what made you decide to go into communications and television.
So I've been a GP for 40 years and seen immense changes in general practice during that time. And it was probably 10 years into general practice as a GP principal that, I was aware that you could see one patient at a time in the surgery, which is a very important discipline, just focusing on that one patient. But you could reach tens of thousands in a broadcast and spread a broadcast message to millions of people. So when there was a public health issue, and the most recent one being, the greatest one for decades, which was the COVID-19 pandemic, reaching those people and giving them the information that they needed in order to protect themselves, and talking about changes in vaccination schedules and the importance of the precautions we took against COVID-19. You couldn't do this on a one-to-one basis in the surgery, but I was aware that you could do it on television and in the media. And so I've been involved in the media for about 30 years. So we've covered subjects like, cancer, spotting the danger signals of a mole, of a malignant melanoma, red flag symptoms of meningitis. And we've had a good feedback. We know that through the programs, we've saved lives. So I think, for me, working as a GP, seeing individuals, and working in the media, combining the two different disciplines has been very important. And, one informs the other. What the people, in the media tell me they want to hear about makes me research, and then I can feed that back into the practice and vice versa.
So obviously your job is as a medical communicator. Why is this so important, particularly in the area of infectious diseases and especially in AMR?
Well, it's what has been so surprising during the recent pandemic is the level of ignorance in the general population. I think as scientists, we assume that the people have a basic knowledge of science, that they trust doctors, they trust researchers and scientists, but they certainly don't. They don't appear to all the time, just as they don't trust the government. So they are skeptical and they question, back in the day, probably what the doctor said was gospel and it wasn't questioned. But now it's much more likely that people will question scientists and go down the line of conspiracy theories that they might see on social media. So this surprised me during the pandemic. But even before that, there was skepticism about, MMR. There was skepticism about other vaccines. There was sort of a lot of concern, largely inflamed by a salacious media, about the side effects of antidepressants, about the side effects of all sorts of medicinal drugs, which had a really good value. So this was of concern to me, and I did two things. I took the jargon out of the communication messages and put everything in very simple terms, and explained from my point of view why it was so important to follow good guidelines with medical evidence.
I guess a follow-up to that, because obviously that is one of the biggest challenges in terms of the public trust. How do you myth bust a lot of the conspiracy theories that might be out there? And you mentioned some of your strategies, like removing some of the jargon, trying to make things a little bit more relatable and easily accessible for the public. How do you and your producers, networks work together to create specific messaging?
It depends on the particular editors of different programs or newspapers. Some will take a more salacious, scaremongering view. It sells newspapers. Other editors want to be more responsible and will ask me for guidance as well. But often it's news-led. So right now we have, for some reason, a lot of media coverage of strep A. And if you look at the figures, they're not vastly different to the figures we saw 4 or 5 years ago. It's just for some reason it's hit the headlines and everyone's panicking. And I know that GPs and hospitals are inundated with worried parents. Every child with a sore throat now, there's probably 10 times as many demanding to seek a doctor and often putting pressure on to be prescribed antibiotics when it's a simple cold. And the whole area of antimicrobial resistance is fascinating. You know that the previous head of the Department of Health,
Sally Davis.
Sorry.
Yeah.
I mean, she's written a book on the subject. And it's fascinating. But even when penicillin was being produced for the first time back in the 1940s in Oxford, that they were aware that there was resistance to penicillin in certain organisms. So it's not a new thing, but because of the overuse of antibiotics in the last sort of 30, 40 years, we now face germs which are resistant, which are very virulent and lethal. And there's still this pressure to overprescribe when it's not necessary, partly because we don't have enough diagnostic tests to see what we're dealing with. As I've said on television in the last few days, you can't look at a sore throat and know what it is that's causing that throat. Is it a viral infection? Just because there's exudation, does it mean it's strep A? Of course, it could be glandular fever. It could be many different things, and you wouldn't necessarily want to use antibiotics in glandular fever, of course. So it's a challenge, and it's very difficult for a GP who's pushed for time, inundated with worried parents, to say, I don't think your child needs an antibiotic, because to try and explain why is going to take a long time. GPs don't have that time, so it's understandable that they reach for a prescription pad and the patient leaves the room.
I was just going to ask, you were saying, obviously, we're kind of no longer in an era where people just implicitly trust what doctors say. People kind of tend to, quote unquote, do their own research and push back. Do you think that for that reason, it's particularly important now that people have a high level of scientific literacy so that they can actually understand what the scientists and doctors are saying and understand intellectually why it's correct, rather than kind of just throwing out the advice?
Yeah, absolutely. I mean, I wish that there was more science on television. There's probably 400 TV channels out there, a TV in every room of every home in this country, and a woeful lack of scientific education. It's all about entertainment. And, I tell my TV bosses this all the time, but, there's probably less profit in talking science and making science sexy. I mean, we've got some very good people who talk about astrology and about various scientific issues, but they're few and far between. I'd like to see more programs devoted to science and new techniques, new discoveries. How do we motivate our young people to think of a career in chemistry or biochemistry, medicine, science in the future, if everything is centered around entertainment? So I think a job needs to be done there, and schools maybe could look at the curriculum. I don't think it's difficult to really influence children at a young age to get them involved in science. It can be made fun, and perhaps it would take preference over certain other subjects on the curriculum that doesn't seem to have changed for decades.
And that's all from us today. Join us for the next episode where I speak to a vet, an ecosystem engineer, and, for some reason, a chemist on the dangerous impacts of antimicrobial resistance on our environment.